Welcome, everyone. Thanks for joining us today for Whole Person Care through Pediatric Collaborative Care, hosted by the AIMS Center. I am Monica Harrison. I'm with the AIMS Center, a licensed clinical social worker, clinical trainer, and practice coach. And I am joined today by my wonderful AIMS Center colleagues, Sarah Barker, the Associate Director for the AIMS Center, as well as Christy Malmstrom, the Program Operations Specialist for the AIMS Center. The AIMS Center helps support organizations implementing the collaborative care model through coaching and clinical training since 2017. We've also developed technical expertise in billing and financing for collaborative care and have gained national recognition in this arena. The purpose of the AIMS Center is to inspire providers, researchers, and decision makers to transform healthcare and improve patient outcomes. We accomplish this by translating and researching evidence-based approaches to behavioral health integration. This call is being recorded, and we'll be sending out a link to the recording and the slide deck to everyone who has registered. This webinar format accommodates our large audience today, and you'll see on your Zoom screen that there is a Q&A function. We're asking you to use that to enter in any questions that you may have for the presenters at any time. We will answer those questions during our Q&A portion and possibly some in between. We'd like for you to focus your questions today on the experiences of these expert presenters. And if you have general questions about implementation or financing for collaborative care, please bring those to our implementation or finance office hours. You can also check the FAQs on our website, and those links will be put in the chat box for you. At the end of the session today, participants should be able to define collaborative care in the context of the pediatric population, discuss how collaborative care can be adapted to meet the unique needs of the pediatric population, and provide some lessons learned and best practices in providing pediatric collaborative care. So I mentioned to you about these expert presenters for today, right? We have a rock star group, Anna Hink, Emily Hannon, Kristen Boswell, Nathan Copeland, Marion Woodruff, and Wendy Pringle. They will each introduce themselves prior to their section, and we are going to get it started off with Anna Hink.
Great. Thanks, Monica. Hi, everybody. Glad to be here. My name is Anna Hink. I'm a licensed social worker and a clinical trainer at the AIMS Center, and have a background in doing collaborative care and have been working a lot with pediatric groups in the last couple of years. So we wanted to just start off and give a brief background and sort of overview of collaborative care and what it looks like, particularly for pediatric groups. So in terms of background, we would just want to acknowledge that pediatric collaborative care is a growing field, both in research and practice. And we're not going to do a deep dive into the need for evidence-based for pediatric collaborative care today, but we do want to acknowledge that the prevalence of behavioral health conditions in children and adolescents is high and likely to increase, and that the need for earlier, more effective, and culturally relevant behavioral health treatment in pediatrics is critical. Research has shown us that treating people earlier in their lifespan reduces the overall negative impact of these conditions on quality of life and reduces the chance of premature morbidity that accompanies untreated behavioral health conditions. Effective treatment for pediatric populations with behavioral health conditions have been shown to be successfully delivered in primary care settings. And I know we're all looking forward to hearing from some practices doing this important work today. So in the next few minutes, I'll discuss the structure of pediatric collaborative care teams and highlight some of the features of pediatric collaborative care. Next slide, please. Great, thanks. So here we're looking at a pediatric collaborative care multidisciplinary team. And please note, while I'm talking today, I will use parent and caregiver interchangeably. And a PCP could be a pediatrician, a family practice provider, or someone in a similar role. So as you can see here, in the middle of the care team is the patient and their caregiver and family member. And so whenever appropriate and possible, the goal is to include the caregiver in the patient's care to support the patient and also to address the interconnected and interdependent web and needs of the family the patients and their families. And then at the top of the triangle, we have the PCP, who remains in contact with the patient once they're enrolled in collaborative care. And then you'll see the behavioral health care manager, who should have some specialized training in pediatric behavioral health care. And then you'll see the psychiatric consultant. The solid lines here are show frequent communication within roles, and then the dotted lines reflect less frequent contact. To the left in the gray box, you'll see common partnerships that can occur within this pediatric model, such as partnerships with schools, community, and behavioral health agencies. And then at the bottom of the screen, you can see the registry. And a registry in pediatric collaborative care, as with adult collaborative care, is used to facilitate a population health approach to care. So some additional points to note about the pediatric collaborative care team is that many teams may include a care coordinator role as well, who gets involved in some of the task sharing with the behavioral health care manager. So the team may have one behavioral health care manager with a clinical licensure, such as a licensed social worker, and then another team member who works on tasks that don't require a clinical license. This is definitely not required for pediatric collaborative care, but this type of task sharing can be a useful approach to mitigate the workforce shortages for licensed behavioral health providers, especially that we're seeing happen in the pediatric field. Additional care team members that aren't listed here, but could be included in a pediatric care team, could include family advocates who represent patients and families in promoting access to care and advocating for needs in the clinic. Next slide, please. Thanks. So now we're briefly going to walk through the 5 collaborative care principles and highlight the pediatric elements. So I won't focus so much on the essential, but you'll see those on the left-hand side. But we really want to look at what stands out in pediatric collaborative care. So in the patient-centered principle, the focus on dual engagement of the patient and their caregiver and family, whenever possible, not only supports the patient's success in care, but it can also help identify the potential needs of the caregiver and recognize that the caregiver and the child's needs are interconnected and interdependent. And this family-centered lens can have an even greater impact on the patient's treatment outcomes and increase the impact on the patient's family. It's also important to acknowledge that the PCP and the behavioral health care manager can play a key role in supporting adolescent patients to navigate conversations about their care with supportive adults and to honor the patient's request for confidentiality under state laws. We must also always consider how patients' consent and confidentiality can be impacted by things like the patient's insurance, if they're under their parents' insurance, and just acknowledge that it's possible that that caregiver could receive the child's behavioral health bill or medication bill and how that might impact their care and their confidentiality. And then lastly, partnerships with school supports and other resources in the community is common within pediatric collaborative care, as I mentioned before, and it's really an essential part of ensuring that the patient gets whole person care. By coordinating services within community resources, we can ensure that care is appropriate, accessible, and culturally relevant to address the unique needs of many different populations. Next slide, please. Thanks, Monica. So under population-based care principle, pediatric collaborative care programs must decide which conditions and ages to focus on when developing their program. A lot of programs might start with a focus on depression, anxiety, and/or ADHD, and then may broaden their scope over time. And then they may also start with adolescents versus starting with a wide age range in the beginning, but they can always expand over time. So defining your population of focus early in care, it can be challenging because we know the need is high across many different conditions and age groups, but it will hopefully help with program drift. Children and adolescents in need of ongoing care and treatment for conditions such as autism, learning disabilities, eating disorders, OCD, and other conditions might be better served by programs offering more specialized treatment. And the behavioral health care manager may be likely involved in coordinating referrals and connection to these services. So likewise, a program will also need to decide their goals for a caseload size. And it's really important to determine consider things like social determinants of health and care coordination needs of your population when thinking about what's your optimal caseload size. In pediatrics, we found that smaller caseloads compared to adults can be more realistic just based on the amount of time it takes to coordinate resources for a patient and taking into account the needs that may be coming from other family members as well. Next slide, please. Thanks. So like any program, you need to consider sort of what behavioral health measures you might use for screening and ongoing measurements, and just have a clear idea of what threshold score for referral you're going to consider. So screening tools like a PSC-17, a SCARED, or a PHQ-9A should augment but not replace clinical judgment by a PCP. Monitoring symptoms may vary in frequency based on the patient's age, developmental level, and caregiver involvement, and by the measure. And your program will need to determine sort of how often they decide they want to collect the parent measure or the child's symptom measures, and just recognize that might differ than doing, with an adult population, doing a PHQ-9 at every visit. Additionally, the systematic caseload review process will generally be broader than just medication recommendations. We're often really looking at behavioral health treatments as the first line of care. And typically, in those SCR meetings, you're going to really take into account as well the psychosocial needs of the family. Next slide, please. Thanks. So treatment in pediatric collaborative care focuses on brief evidence-based behavioral interventions as the first line of treatment. And these types of treatments could include things like CBT, behavioral activation for adolescents, parent management training, solving sort of focused training, as well as ongoing psychoeducation for the patient as well as their caregiver or family members. Medications will be considered when necessary, and recommendations from psychiatric consultants can be incredibly supportive in this process. And we just want to recognize that specialized training for behavioral health providers and PCPs in these evidence-based interventions is highly recommended. So for accountable care, it happens both at the care delivery and the organizational level, similar to adult populations. And we want to recognize that program drift can happen across age and conditions, and it's really important to frequently check in with your team and just sort of make sure everyone's on board and understands the scope of the program. Considerations for accountability in pediatric collaborative care is really thinking about bringing in potentially a family advocate to help support quality improvement and program development. So a family advocate is typically a parent, a caregiver, or a family member of a patient in the clinic who has received care at that practice. They will often partner with the practice to ensure that the program is inclusive and family-centered. And they may participate in planning, implementation, and program evaluation activities in terms of meeting with the clinic and providing feedback. Programs can compensate family advocates for their time, and that might increase the number of families available to participate in that role. But practices could likewise also just choose to survey families who have opted to give feedback on the program rather than hiring someone into a family advocate role. And then in terms of program sustainment, we just want to consider that programs have potentially a lower caseload than adults, yet they may be getting the same reimbursement rate for each patient. So thinking about how that might impact your program and the finances. And additionally, it's often common that behavioral care managers will be providing services and coordinating with schools, family members, lots of different programs, and they may not always be able to be reimbursed for those minutes. So wanting to take into account that as well. All right, thank you, Monica. That's sort of the end of the principal piece.
Awesome, thank you, Anna. Up next is Western Wake Pediatrics.
Hi everyone, I'm Emily Hannon. I'm a pediatrician at Western Wake Pediatrics. We are an independent practice located in Cary, North Carolina, which is a suburb of Raleigh. And we're really happy to be here today. I'll let my teammates introduce themselves when they join on. Actually, maybe now you should introduce yourselves. Could we spotlight Kristen and Nate?
Hey everybody, I'll introduce myself. Good to see you. My name is Nathan Copeland. I'm a child psychiatrist at Duke. Clinically, mostly work with autistic and neurodiverse kids and adults. But then a large part of the rest of my efforts is focused in integrated care, development of collaborative care, a lot through the North Carolina Psychiatry Access Line, which we'll have time to talk about. And I'm here at the privilege of Western Wake Pediatrics and our intersection developing pediatric collaborative care with Western Wake.
Awesome. And hello, everyone. My name is Kristen Boswell. I am a licensed clinical social worker associate and behavioral health care manager at Western Wake Pediatrics in Cary, working closely with Dr. Hannon, Dr. Copeland, and the rest of our team to provide collaborative care services to our patients. Happy to be here.
So I first got interested as a pediatrician in the collaborative care model when, as a general pediatrician, I was calling our North Carolina psychiatric access line, what we call NCPAL, frequently when I had patient questions about medications or if a kid needed to get connected with community services. And our NCPAL line is modeled after the Massachusetts Child Psychiatric Access program, which really has was a model across the whole country. So I'm hopeful that you listening, your states have similar lines, because it was really useful to have a direct connection with a child psychiatrist who could help answer some of my questions. And then moving on from that, I joined a REACH training that was provided by the Duke NCPAL program. And I got further information about how I, as a pediatrician, could better help my patients. And it was in one of those REACH training sessions that I heard first about the collaborative care model. And it really piqued my interest, and I was really interested to learn more and see how I could bring that model to our clinic. Next slide. So we are a single site independent physician-owned pediatric practice. Western Wake Pediatrics has been in the community for over 30 years. We have 6 pediatricians, 3 pediatric nurse practitioners, 1 lactation consultant, and now, as of a year ago, a behavioral health care manager with Kristen. And so I would say we're a moderate-sized independent practice in our area. Next slide. So I talked a little bit about my interest in the collaborative care model, but I want to tell you a little bit more about our interest as an office, as a practice. So we were seeing long waiting lists for community-based therapy. Now, we're in a suburb of Raleigh. This is a really well-resourced area. Yet still, we were having patients who were waiting months and months to get connected with a community-based therapist. Our physicians and nurse practitioners really wanted to learn more about psychiatric care, both the diagnosis and the treatment, even before the pandemic started. But then in the wake of the pandemic, of course, as you all know, across the country, we were seeing increasing rates of depression and particularly anxiety in our kids who were stuck at home for over a year doing remote schooling and all the things that went along with the pandemic. In our office, we really strive to have wraparound services for our patients. We wanted to be able to provide the needs of the patients. We wanted to be able to provide that here in our office in what they know is a comfortable and familiar environment. The kid would not be nervous about coming here because they've come here since they were born. They know our office, they know our staff, they know where to get the stickers. So it was a comfortable place for them. And then we also wanted to provide the care for our patients, but we know that you can't always do that in a 15-minute appointment slot. So how do we leverage the resources that we have or the resources that we could build in order to provide that longitudinal care for our patients? And I'm going to pass it off to Kristen for the last part of this slide.
Awesome. And yeah, so as the behavioral health care manager in our office, like I mentioned before, I am a licensed clinical social worker associate. And so I am able to provide brief therapy services to these patients who are referred to collaborative care. And so our aim as far as age falls between the ages of 6 and 21. And as Anna mentioned earlier, of course, with pediatrics, this is a pretty widespread age range. And chose this age range in particular based on screenings that we have available that are evidence-based, primarily diagnosing or working with individuals with diagnoses of ADHD, anxiety, and depression, as these have been the most common amongst our population. And so I am able to work with families and patients under this age range. So some of those younger 3, 4, and 5-year-old parents usually. And so with them, I'm often helping refer them to appropriate resources such as OT, play therapy, parenting programs. If you're familiar with Triple P, that is one I'm trained in as well. So these are just some services in the age ranges that we work with commonly. And then I also participate in IEP and 504 plan meetings, collaborating with schools as a patient advocate, as well as a representative for our office. And oftentimes these meetings and these plans in general can be confusing and tricky for parents to navigate or to even know how to ask teachers or the school how to get set up with one of these plans for accommodations for their child at school. And so even as providers, this is sometimes a little bit tricky of a step. And so me being present for those meetings in order to support the patient as well as the family as a whole is a huge thing and is really seemingly important to the families and helpful for me to be a part of those meetings, to advocate for their child, to ensure that they are getting the best quality accommodations and interventions in school to help them be successful. And then last but not least, another role as behavioral health care manager includes safety planning and suicide prevention in our office. As mentioned before, the youth mental health crisis and the increased rates of teen suicides continue to grow and increase. And so by providing safety planning and screenings within our office, we hope that this will be supportive to patients and hopefully, at least in our community, reduce some of these rates. And through Safety A training, which is a training that was provided to me upon being hired as behavioral health care manager, which Dr. Copeland will likely discuss further on another slide, I was given an outline, the tools, as well as the confidence to be able to appropriately safety plan with patients and be confident that they have the tools within themselves to stay safe. And of course, there are still times when it may be necessary to refer patients to behavioral health care urgent cares or emergency rooms within the area, but I'm able to provide that one-on-one support in helping them get to that point. And I often work as a team as well with their PCP or the on-call provider that day to help facilitate this when necessary. Next slide.
So we can talk a little bit about billing and return on investment. I know as an owner of our practice and a physician that I was really keenly aware of this. How were we going to make this work financially? So these are the billing codes that we use in our office. In North Carolina, all of these codes are paid for by all of our major insurance carriers, including our 5 Medicaid state-run plans. And so that has been really useful. And we have been in operation here since July of last year. And we are, I would say to, the pediatricians, we're breaking even on this. So this is a huge service for our families. We are covering our costs of having Kristen here in the office, and providing that service for our families is fantastic. What's not accounted for in this return on investment is the time saved from the pediatrician perspective. So using Kristen as an adjunct, as an extension of my services, allows me to continue to see other patients. I am not able to attend IEP meetings, and if I did have the desire to do that or the time to do it, it would take me out of the clinic and seeing more patients. And so that all wraps into, so I just wanted you to have this information. Next slide.
And so just wanted to give you sort of a virtual tour of what my office looks like. And so this is a present picture of what the space looks like. And it was transformed from a traditional exam room that you might see in any pediatrician's office with an exam table, the bigger trash cans and things like that. And so it's clearly much more warm and inviting and cozy, just with the addition of a rug, some comfy chairs and lamps, which are all really important in a therapeutic space for patients to feel welcomed in and be able to be comfy, since they are oftentimes sitting in these spaces for longer periods of time. And so right outside of my door as well is a bench where parents or caregivers are able to sit while I meet with the patient individually. And this is important just again for their comfort and not having to go all the way back to the waiting room, since they're often involved in the process as well, have to bring them back in. So it just keeps them close by. And as you can see in the picture as well, though, we do have an air purifier in the office that also kind of serves as a sound or noise machine as well to give the patient privacy within the office. And what's not pictured here is the endless amounts of fidget toys, books, games, and art supplies that I often use, especially with children in these sessions as well, which are stored away in those cabinets.
Great, thanks all. As I said before, my name's Nathan Copeland. I'm a child psychiatrist at Duke, but then I'm also a psychiatrist with the North Carolina Psychiatry Access Line, which Dr. Hannon mentioned. And NCPAL supports pediatric providers and perinatal providers across the state in multiple ways. And we at our heart view ourselves as an educational service and delivering evidence-based practices across the state of North Carolina. Well, over the past couple of years, North Carolina has really been expanding its efforts to grow collaborative care that has involved bringing in private payers to agree to billing codes, increasing Medicaid reimbursements, our AHEC partners in the state as well, being tasked with supporting community practices across North Carolina in building their own collaborative care panels and thinking about billing and infrastructure and practice readiness and things along those lines, and having practice support coaches through AHEC supports primary care practices. And we were asked by the state as NCPAL to help support the development of these pediatric collaborative care programs. And where we thought we could best fit was similar to those other education services, but is developing educations and trainings for a behavioral health care manager that whichever staff a pediatric practice hires, we could rapidly train a behavioral health care manager to be ready to serve in that role. At Duke, we've been doing collaborative care since about 2017 and pediatric collaborative care since 2020. And here you can see a list of the trainings that we put together. First is the AIMS Behavioral Health Care Manager course. And then the REACH training, which Dr. Hannon mentioned, which is a weekend primary care pediatric mental health course that goes over a lot of the screening scales that we use, medications that we use, different types of therapies, and provides education in that way. So regardless of the background of the behavioral health care manager, we could get everyone up to speed and thinking about best practices in pediatric mental health. Motivational interviewing courses, and then focuses in the development of behavioral activation and exposure therapy concepts, where I believe the next group will talk about the FAST trainings. We will use those as foundational trainings in depression and anxiety and parent management, while also continuing to develop those skills in the care manager over time. And then the last piece that Kristen mentioned is the safety aid training. One of the things that we have seen as we have had our own collaborative care panels and staffed our own collaborative care panels within our own institution, is how important it is for behavioral health care managers to have comfort in managing crises and thoughts of suicide and thoughts of self-harm, and having those skills to ensure that patients get to wherever they need to be. And also for the care manager's own well-being, of feeling comfortable in this space, of feeling comfortable working in very complex and complicated situations. The other really cool thing that we have seen in training behavioral health care managers and community practices in safety A, this evidence-based modality developed by Dr. David Goldston and Joan Azernow for safety, is pediatric practices that we partner with now have a person at their practice that can do safety planning, which is really cool. And I believe Dr. Hannon herself had actually participated in the safety aid training so that she could develop those own skills. So extending that education tool in other ways. The other thing that we are able to do as an access line, because we have a number of child psychiatrists that staff the access line, is we are able to use our child psychiatrists to also provide the pediatric psychiatric consultant role for the practices. So we're able to tap into our own pool of child psychiatrists to be able to serve as that psychiatric consultant role for a period of time for the practice, to help things get up to speed, to help the program really get moving. And then the last thing that I have here that we support in training is we host a bi-weekly learning collaborative between the different care managers of the practices that we work with for a few different reasons. One, so that care managers can talk about ways that they've solved problems, different solutions that they found in working in collaborative care in the community, so that we can identify other training needs and be able to support those training needs across a group of people. And lastly, to create camaraderie among behavioral health care managers. A lot of behavioral health care managers that might exist in the community might not know other behavioral health care managers, and to serve as an opportunity so that they can support each other, and be able to talk to each other about this really unique role that is a BHCM. All right, next slide.
So I just wanted to briefly show, we'll share these slides, but a patient consent form that we give out to our patients. And so I'll end by passing it on to the next group. Show that is just to tell people what our collaborative care model is like, with a nice picture of Chris and a little description of what we do in our office. Next slide. And so I want to direct people to lots of information on the University of Washington Ames website. I also want to stress that I think it's really, really important for your practice, if you're interested in starting the collaborative care model, to define a physician or provider champion. There has to be somebody who is going to follow this program through. From the time when I first got interested in it to the time when we hired Kristen and it started working was a full year. So it really does take somebody who has dedicated effort to this. And then I would encourage you to talk directly to your clinically integrated network, to your AHEC office, to your local academic medical center that might have or house your pediatric psychiatry department. Lots of resources that you can tap into in your state. Thank you.
Thank you. Next up, Hope Sparks and Pediatrics Northwest.
Well, thank you, Ames colleagues, Drs. Hannah and Copeland, Kristen. It's great to be here with fellow collaborative care travelers. I'm Marianne Woodruff. I'm a general pediatrician in practice at Pediatrics Northwest in Washington State, where I co-lead care transformation and have created pediatric collaborative care with my colleague here, Wendy Pringle, that collectively we've all termed the Bridge of Hope. We're super excited to share this work with you. And perhaps this quotation from Gregory Boyle's book, The Whole Language, sums up what has driven our work. We can rest in being reactive and relatively adept at responding to situations that arise. We can sit around and wait for the need that comes up, the crises that present themselves. But rather than settle into reactive dexterity, we want to always be attuned to be proactively relational.
I'm Wendy Pringle. I'm the Senior Director of Pediatric Healthcare Integration at Hope Sparks. I'm a licensed mental health counselor, and I have been working for the past 5 years on integration. Since 1895, Hope Sparks has been a recognized leader in behavioral health, early intervention, kinship care, family services, home visiting, and parent education in the Tacoma, Washington area.
And Pediatrics Northwest is a multi-specialty pediatric group with 25 pediatricians, 4 primary care offices in the South Puget Sound area of Washington State, founded around 45 years ago, embracing a primary care medical home model. And we care for about 35,000 children and youth, over half insured by our state Medicaid insurance. Our organizations with missions aligned came together in 2018, thanks to a grant to establish integrated mental health care right at the primary care medical home, utilizing the pediatric collaborative care model. We began in March 2020, just as the stay-at-home orders for the pandemic were issued. The timing it turned out to be serendipitous, as by necessity, we did virtual visits and still do. Our Bridge of Hope partnership has resulted in a flourishing integrated behavioral health program that is both effective and scalable. Next slide, please.
All families served by the practice are eligible. Our data shows that our referral demographics match the population served at Peds Northwest. All primary care pediatricians at Peds Northwest are part of the team. The integrated therapists are employed by Hope Sparks and serve each of the 4 clinics. We have 2 psychiatric providers, and they are psychiatric ARNPs. Our team also has community health workers to support the social health needs of our families and help support any needed referrals. Our program has been successful because of the buy-in and the commitment of both organizations.
Next slide, please. So it starts with universal screening at well-child visits at our practice. Currently from ages 4 to young adult, but soon to include families with 3-year-olds as well. And we seek to identify children and youth with mild to moderate anxiety, depression, and perhaps behavior concerns. And we use a pictorial screening instrument that identifies any social health needs that families would want help with, rather than simply identifying lists of problems. After reviewing the results of screening, along with the narrative information gleaned during the visit, we identify those with these mild to moderate concerns who would benefit from referral into collaborative care, careful to explain that all sessions will be virtual, that parents can join from work or home, and that this is a 2-generation approach. We request verbal consent and then place the referral to our integrated therapy team into Epic, our electronic health record. We let the family know that the therapist will contact them in just 1 to 3 days. Next slide, please.
We are tracking on a registry for ongoing measurement to determine the level of improvement and the level of engagement. We know who's getting better and who's not, and no one's overlooked. Treatments are reviewed every 4 to 6 weeks and actively changed until the clinical goals are achieved. We use a model called the First Approach Skills Training. It was designed by the psychologist at Seattle Children's for primary care so that mild to moderate needs could be addressed in the medical home. It's an evidence-based treatment based on cognitive behavioral therapy. Children, youth, and their caregivers gain new insights and tools as they participate in weekly 20 to 30-minute sessions. We use FAST-A for anxiety, and we use it for children ages 5 and up. FAST-B is for behavior challenges, and it's used for ages 4 to 11. FAST-E, which we're just in the process of implementing, is Fast Early Childhood, and it's for caregivers of children aged 3. FAST-D is for depression and used for ages 12 on up. And FAST-P is for caregivers who are parenting teens. We use a stepped care system to ensure that families get access to, as we like to say, the right care at the right time in real time. We see nearly 2,000 families with an 89% connect rate from PCP referrals. It's an average of 2 days until the family engages with their therapist. We utilize universal screening at well-child visits to determine mental health needs. So this stepped care system might include brief support from the primary care provider, collaborative care, referral to specialty care such as Hope Sparks outpatient services, or referral to crisis services. Our goal is to treat those with mild to moderate needs in the pediatric medical home. All families are introduced to community health workers to ensure that they know where they can go to get access to additional support.
Next slide, please.
We use a data-informed approach to ensure that patients are getting better. There are significant decreases in symptoms after treatment. The fourth column shows the effect size of the treatment, which ranges from 0.60 to 1.10. The changes from baseline to the end of treatment were all above the medium range. So the results are not just statistically relevant, but clinically meaningful to the patient. There is a medium to large effect size, which dramatically impacts the way our patients experience life on a day-to-day basis.
Next slide, please. So collaborative care is really vital in transforming pediatric primary care as a systematic way to address mild to moderate mental health concerns right at the medical home with expert teams of care. This upstream approach produces results in expected and unexpected ways. It's about a relational reset and support, not offering a laundry list of suggestions. And families embrace this really accessible help when offered. There's less waiting, fewer phone calls, and they learn skills together as a family. With effective teams, we are able to address barriers to care and social health needs, especially utilizing our community health workers. The whole team learns together. Everyone's knowledge base increases both in deliberate and organic learning. As pediatricians, frankly, we prescribe fewer medications. And when we do, we have consultative help from the psychiatric provider. The team members, frankly, are happier. We see this as a workforce solution. We have a very low turnover rate of our therapists. In fact, 0 over the past 4 years. And the same with our psychiatric consultants. Collaborative care is financially feasible, insurance agnostic, and shifts from expensive, episodic, and crisis care to prevention, early identification, and brief evidence-based treatment. And as you heard Wendy say, our Bridge of Hope team says our goal is to provide the right resource at the right time in real time in partnership with the families we serve, being mindful of the need to connect families to services rather than handing out more phone numbers, fingers crossed. We think that foundational investments upstream in supporting relationships makes all the difference. You can go to the last slide. And this is basically sums up how we feel about collaborative care.
That's a good sum up quote right there. I love that.
Thank you.
Well, many thanks to all of our presenters. It's really valuable to hear from the individuals who are stepping up to figure this out and are willing to share their learning and lived experience with all of us. So I thank you a trillion times over. We are now going to go into our Q&A portion. So it is time for questions. So Sarah Barker will read from the questions that were submitted, or maybe a compiled of things that are there, and then have some of our presenters respond.
Okay, great. Thanks, Monica, and thank you to the panelists. The first questions for both groups, I think, is around the registry. And so could you talk a little bit about your registry strategy? I'd also be curious about what symptom monitoring measures you track in your registry. So I don't know, the North Carolina team want to start?
Yeah, I can share. And so currently we are using the AIMS caseload tracker. This was developed, I believe, Dr. Copeland, jump in if I'm incorrect, by the NC Department of Health and Human Services. And within our tracker, we are using the PHQ-9, the GAD-7, the SCARED, as well as parent and teacher Vanderbilts within our caseload tracker to track those symptoms for the ages mentioned prior.
Yeah,
and so it's a little different from practice to practice.
absolutely. And if they're, so we are between AHEC and a group called CCNC in North Carolina, and this effort to expand collaborative care across the state, it was a recognition that everyone's going to need a registry. And so one of the most effective ways to try and help make that work is for CCNC and AHEC to have, in partnership with AIMS, develop a caseload tracker. And so primary care practices in the state that demonstrate practice readiness or in the process of moving towards implementing a collaborative care program get access to this registry. I believe for 3 years, something along those lines is currently what is being said, but a lot of this was launched in past year or two or so. So we'll continue to see where that was, but it was a big effort from the state to try and just say one of the biggest barriers is having a registry. Let's see if we can provide a registry for everyone that needs one, and to get those practices off the ground.
Great. And how about the Hope Sparks Peds Northwest team?
So for us, we created our own registry because there weren't all of the measures that on the registry, and then it is it's based, an Excel based spreadsheet, and all of the data, our data analyst then loads that up into Power BI to create reports. And part of what we wanted to also track was tracking data about which treatments were used in particular and the effectiveness of each of the treatments. So that's another thing that is tracked, as well as all of the assessments. And of course, the standard things like, flags and site consults and all of those basic things. So that our data analyst helped us a lot in getting all of that set up.
Thank you. There are a couple early questions around kind of what to build into an intake document when you're thinking about collaborative care, pediatric collaborative care. So can you talk about kind of key elements to have in those note templates for your behavioral health care managers? Either team.
I would say that we take kind of a brief, we kind of used a brief model of what was used in our outpatient clinic, but really focusing on symptomology, because that's really our goal. It's really about how can we decrease symptoms. And so I would say that that's one of the key elements. And because we have access to Epic, we do have access to all the past information if that's needed, but it's really about what's happening right now for this child and for this family. So I would say that that's like the key element.
Carolina team?
Yeah, I would completely agree with Wendy, kind of figuring out in that intake session what is the presenting problem or the stressors for the patient, the individual, as well as the family. Another thing we definitely take into account in that initial session is strengths or resources that they already have as an individual or a family, and how we can hone in on those and use them to help support them moving forward. We, of course, already have in their patient charts any previous medical history. Always kind of touch base on that as well, and any current medications that they may be taking. And then also usually screen for safety and use our screeners in those initial sessions as well.
And I saw as well, as a psychiatric consultant and a template, I think lots of collaborative care panels can be built in different ways. We very much, both internally and in our pediatric practices, rely a lot on what the behavioral health care manager has in their notes. And so very frequently, the behavioral health care manager, their note looks very much like a clinic note, which is functionally, I think that in lots of ways, the behavioral health care manager is serving as a clinician who has 30-minute appointments and 30-minute visits and hour intakes and things along those lines. And so what I'm usually looking for in these notes is kind of a brief HPI, those screening scales that Kristen was talking about, the PHQ, GAD, SCARED, Vanderbilt's, depending on what we're getting. Really like to talk about strengths and resources of that kid and areas of growth. One thing that we also really like to lean into in a behavioral activation sort of way is also developing SMART goals. So what are the goals that we are helping to establish for that kid? What are the whether that's behavioral activation or some element of exposure therapy? Are parents on board with those goals? How can we ensure that over the next week or 2 weeks that the family has something that they are working on? And so that's often the template that we're kind of looking at for kids that for system documentation purposes. Also very much like to see a safety plan if the safety plan has been created with that kid as well, just so something can live in our own documents and records that we can refer back to ensure that safety has been addressed.
Great, thank you. There were several questions around kind of structure of the sessions for that behavioral health care manager role. So how long are your visits, maybe for that initial assessment and follow-up visits? So I don't know if both teams want to start there. Wendy, you want to start maybe?
Yeah, so our first visit is we allow an hour to get all of the information and understand. And because we use the first approach skills training, we actually have the family leave with something to do and to work on during that first week. And then our sessions are 20 to 30 minutes weekly, and the average stay in services is about 3 to 4 months. We use the model where we have the intake piece, then we have active treatment, and then we do follow up after that treatment time for another 1 to 2 months to make sure that their family isn't experiencing any additional challenges. So we will do really brief check-ins with them for the next 2 months.
Kristen?
Yes, and so of course this might look different from practice to practice. In our practice currently, just based on caseload and size, I'm currently meeting with patients on a bi-weekly basis. So every other week, our intake session is the same amount of time, so roughly an hour. Sometimes blocking a little additional time, more than an hour for documentation purposes, or if there's safety planning is necessary, that does take a little bit more than the hour time, which is not on a regular basis. So just keeping that in mind. And for the biweekly follow-up visits, usually between 30 to 45 minutes is the aim for the time spent with patients in those visits. And so since we are seeing them on a biweekly basis, the average patient is in the program for about 6 months.
Thanks so much. So perhaps this question is great for Dr. Woodruff and Dr. Hannon around kind of recommendations on education and support for PCPs, the medical team, especially distinguishing between collaborative care and other kind of models or approaches, or maybe referrals out to services. How do you talk about the program with your patient?
Well, I'd love to start on this, because we've spent a lot of time really thinking initially, like, how would we educate everyone? And in fact, that's what we did. We set out for everyone at the practice understands collaborative care and understood it from the beginning. So, and we defined all the roles, whether you were the front office staff, the back office staff, the pediatricians, but our administration had buy-in as well. And really everyone knew about it. And what we knew too is that the real risk would be that our therapists would be overwhelmed if we said that this integrated program took care of every need. It could not. And so we wanted to make sure that people realized that there are really specific kinds of issues that collaborative care using the FAST curriculum would dovetail with the best. And that's really worked out. But it's also meant that we do continuous education too. So we rolled it out one office at a time, so that not to overwhelm anyone. But we continue to do ongoing education and my colleagues are invited to case review sessions, and they do that when they're able to. But we also do a lot of lunch and learns where we take our team members, both the community health workers and our integrated therapists, to each office and just sit with our colleagues and the staff and answer questions and really find out what increasing dreams do they have. And just saying too that we're developing a real focus at the practice around developing family partnership. And it's from families themselves that we have gone now into the 3-year-old space who requested they wanted these services. And so increasingly, we have a family partner leader, so that we're saying that we want to build the processes at our practice with family co-creation, not just like advisory after the fact.
Yeah, that's great, Marianne. And I'll just add too that we actually did look at both models, both the collaborative care model or the model of hiring a psychologist to be in our office co-located, but sort of running their own practice. And what I found from my colleagues around the state was that people who did that model, the provider filled up really, really quickly. And within a couple of weeks, they were full for 6 weeks out. And we wanted to try and avoid that. We wanted to keep availability so that our behavioral healthcare manager could, help with immediate safety planning if needed. And I've pulled Kristen in a couple times to see a patient on the spot. And so having her to be available more frequently and not booked from the minute she walks in to the minute she leaves. We have had to do some continued education, like Marianne references, about what is the proper referral to collaborative care. When we started out and we just wanted to get families in, we were a little more loose with referrals. And now we're having to rein that back in to get Kristen to a more manageable patient panel, which for pediatric collaborative care is around 60 to 80 patients to manage that panel.
Thanks for clarifying that, Dr. Hannon. Thank you all for answering questions live and answering questions in the chat. 100% appreciate it. We are running to the end of our hour, but wanted to also provide for the attendees some additional resources for those that are interested. Here are a few of them here, a link to our pediatric implementation guide that we have on the AIMS Center website, a link also that was also put in the chat box for our implementation and finance hours. There were a couple of billing finance questions that I saw in there that people had questions about. And then also a link to the AIMS caseload tracker that you did hear referenced earlier that North Carolina uses. We've added the pediatric, some pediatric scales there, the SCARED, the Vanderbilt, and the SMFQ. So just some links there for those who are interested. I think I also saw there were some questions about training. So there is fast training that's out there, as well as training provided by the AIMS Center around behavior activation, problem solving, treatment. So the things are out there. We're more than happy to help direct you to them. So feel free to reach out to us, join our listserv if you're interested in that as well. And then we have some upcoming quarterly webinars. We're able to bring these quarterly webinars to you for free. So we do ask that you fill out the survey that was dropped in the chat box, because that helps us to come up with, is this a good thing or not? And what are the topics you might want to hear about? So coming up, we're doing a special topic around, this is our 20th year anniversary as the AIMS Center. So an opportunity to hear from Anna Rotzlev, Dr. Jurgen, as well as Diane Powers, just around how it began, where it's been and where it's going in terms of collaborative care. And then also our spotlight or highlight on rural populations. So working with collaborative care in the rural population. So those dates are set, those topics are set. So we encourage you to register for those as you see those come up. Join our listserv, because we do send out reminders that they're coming up. And again, fill out our webinar link that Christy has dropped in the chat box. And we hope that you all have an amazing Rockstar Day.